Hello, let's talk about luteal phase defect. I'm going to put it slightly differently, the upstream cascade, and often on women who have got a shorter cycle, 25 days, 23 days, 24 days. So let's look at the key part. Where does this all start from? This all starts from the egg. What happens? It releases progesterone, and that has an effect directly on the uterine lining. So it's twofold. If you're looking at luteal phase defect, you're looking at a twofold effect. In short ovulatory cycles, the timing is compressed. Let's understand the gray zone of fertility requires looking upstream, which means looking beyond just the uterine lining, where the quality begins to dictate the success till the end. So if you look at the diagnostic criteria of the gray zone, what happens in a normal cycle? In a normal cycle, you are seeing ovulation occur around day 14 and a 14-day luteal phase. When you ovulate, let's say on day 12 in a 25-day cycle, your luteal phase gets shortened to 11 to 13 days. While luteal phase defect on a cycle is defined as anything less than 10 days, shorter cycles, there could be a possibility that conception would fail. This is the gray zone, technically normal duration. So luteal phase dysfunction is just more than a short cycle. The duration is less than 10 days. 8.9% was short. 8.4% had low progesterone. Only 4 simultaneous. And you see resistant, that is endometrial failure. So if you look at the quality of the end, it begins at the start. There's where I'll differ from a lot of thinking that everything in luteal phase is at the end. The architect is looking at the follicle. It is this follicle which contains an egg, and these cells around it eventually after ovulation will start secreting progesterone. So the egg is released, the empty follicle starts collapsing, and that engine that is formed is called the corpus luteum. This is what secretes progesterone. The corpus luteum is not a new organ. It's not something that comes out of the blue. It's a transformed remnant of the follicle. If the follicle develops poorly due to low FSH stress, then the resulting corpus luteum that is formed is going to be weaker, and this corpus luteum is not going to let you produce adequate progesterone. So what do you mean by having a good corpus luteum? High lipid droplets, rich blood supply, good LH response. To produce progesterone, these cells, they luteinize, develop liquid droplets and enzymes. This process depends on a strong mid-cycle LH surge. If that is less, the corpus luteum is less. Without robust surge, this engine fails to develop. What happens? Poor luteinization, poor amount of stimulation, low energy capacity. What is the most important hormone? The pulsatile messenger. Progesterone is secreted in pulses derived by LH levels, and these can fluctuate in 90 minutes from 5 to 40. So a single blood drawing captures a valley and might falsely diagnose a deficiency. So again, looking at just the progesterone, not something which is fine-tuned, because it can vary. The most important thing is, so look at it from this. the follicle, the egg, the progesterone, and finally the uterine. Progesterone changes the endometrium from what you call as a proliferative phase to what is a secretory phase. Expresses adhesion molecules necessary to catch the embryo. Without sustained progesterone, this conformation is incomplete. So when you look at the implantation window, and if you're looking at the window opens 5 to 7 days after ovulation. In a 25-day cycle, it opens at 17 to 19 days. That is when the window of implantation opens. If the corpus luteum regresses, then this progesterone level starts dropping sooner. And as it stops dropping sooner, the lining begins to shed before the blastocyst can complete implantation. So why does a follicle fail? Multiple reasons. Stress, weight loss, hypothalamic, thyroid abnormalities, PCOS. Luteal phase defect is not a disease, it is a symptom. It signals the disruption of the hypothalamic pituitary function, that's there, and caused often by thyroid dysfunction, hyperprolactinemia, stress, and extreme weight loss. Is a biopsy recommended? The answer is no. Single blood test? The answer is not really. Endometrial biopsies cannot distinguish fertile from infertile women. Diagnosis relies on ruling out underlying conditions and tracking cycle patterns. Serial ovulation kits and mid-luteal progesterone 6 to 8 days after ovulation. So it's strategy first. The simple way, you can keep on spending time trying to diagnose it. The simple way is improved follicular development. What does that do? Improves the amount of granular cells. That creates a stronger corpus luteum. That creates a sustained progesterone. Even if then things change, then it's more likely to be the endometrium. Strategy 2, support the luteal phase. How? Give exogenous progesterone, maintaining implantation window. The evidence for progesterone is mixed. It is low risk, doesn't cause any harm. One observation study shows significant pregnancy rates in unexplained infertility using progesterone alone. This may extend the window long enough for implantation to occur. So let's look at the summary. Small follicle, weak corpus luteum, bleeding starts early. Larger follicle produced by clomiphenoletrozole, robust corpus luteum, window stays open, possible pregnancy. A short cycle isn't always a barrier, but recurrent short luteal phases warrant investigation. Often we can't find the cause. We can stop chasing symptoms and start fixing the source, the ovary, and that is incredibly important.